Good morning, everybody. This is A.J. Heitman, the Editor-in-Chief at JEMS, and welcome to today's webcast, Cardiac Arrest, Should Unaided CPR Be a Thing of the Past? Today's webcast is going to be presented by Dr. Joe Holley, who's going to talk about CPR, the cornerstone of resuscitation for patients in cardiac arrest. You know, it's remained essentially unchanged for more than 50 years, yet survival rates for patients suffering from out-of-hospital cardiac arrest hover at about 10% in many systems. So the question is, how can we improve outcomes and survival rates? The goal of this webcast, sponsored by Zoll, is to discuss some of the new tools that'll help us get more from our CPR and more resuscitations, because we have evidence to show that we can certainly do that. I'm going to give you a couple of housekeeping notes, and before we get started, this presentation is both live and interactive, so you can ask questions at any time by clicking on the Ask a Question button in the presentation window. We'll answer your questions or combine a few if there's several that are the same during the Q&A portion at the end of the webcast. So if something isn't covered or you'd like it to be covered, just ask that question, and we'll be doing our own little JEMS triage here at the office. If you're running a pop-up blocking software, you'll need to disable it to be able to view the webcast. If you have any problems, just let us know, and our staff is on hand to be able to help you mitigate those. In addition, it's recommended that you close all other applications for better performance of your system. For your convenience, this presentation is also going to be available on demand within 24 hours of the live event. A reminder email message will be sent to all registrants with a link to the archive. It'll also be archived at jems.com, and a PDF will also be available to you to use within your system and other places by clicking on the event. I'd really like to thank our sponsor, Zoll, for stepping up in this really important time of resuscitation change and for supporting today's webcast. Now it's my pleasure to introduce our speaker, Joe Holley, well known to many of you. Probably most of you as the medical director of the Memphis Fire Department, as well as numerous EMS agencies in his region, including Collier Fire Rescue, which he did a great article on that'll be in December JEMS, and their dramatic changes from some of what we're going to talk about today. Joe's a very active member of the Metropolitan Medical Director Eagles Coalition, and also serves as the EMS medical director for the state of Tennessee. So there's nobody better to talk about this topic than Dr. Holley. So, Joe, I'm going to hand it over to you.
Well, thank you so much, AJ. It's a real privilege to be here, and I appreciate the opportunity to talk about a topic that I'm very passionate about. What we'll do today is we'll just sort of talk a little bit about the cardiac arrest and kind of where we are today. I think everybody has a pretty good sense of that already. We want to spend a little bit of time on the physiology of CPR and what's really important about getting that right from the impact that it has on our outcomes and our ability to resuscitate these patients. And I've been really very blessed to work with an amazing bunch of people to develop a human cadaver model for CPR, and I'm eager to sort of show you the things that we have learned and have been able to ascertain from working with that model. I've tried to make sure toward the end of the time here that we'll have plenty of time for questions. I'm happy to talk about anything that anybody is interested in related to what I've been doing in CPR research, et cetera. So with that being said, let's kind of jump on into the rest of the program here. It's not a surprise to anybody that, cardiovascular disease continues to be one of the leading causes of death in the U.S. And it is really a shame, I think, that despite a lot of variability across the country and the quality of resuscitation and the difference in survival rates that we see all around the country, that still the average is around 10%. And I think a lot of what we want to talk about today is what can we do to try to improve some of these outcomes, and what sort of thing we need to be working on to see if we can't make a difference and move the needle a little bit. Some of those things involve a national registry of cardiac arrest really to monitor performance and track progress. I think that there are lots of different models for that out there, including the CARES registry and others. But I think the important thing here is that data is absolutely important when it comes to cardiac arrest, and our need to make certain that we're all looking at metrics and we're all paying attention to those details, simply because the cardiac arrest in general is very much a black box to some extent, and it's really challenging to understand the impact of lots of different changes in CPR, adjuncts to CPR, methodologies, medications, et cetera, and how they affect ultimately patient outcomes. I think education to the public remains a cornerstone of cardiac arrest survival, from early recognition to what to do when you actually do interact with a patient in cardiac arrest. Those numbers, while better than they used to be, are still not where they really need to be. There's obviously things that we can do within our hospital systems to improve post-resuscitation care. I'm not going to spend a lot of time on that today, because I think that's a whole topic all its own. I certainly think quality improvement programs are vitally important. Again, we talked about that earlier, related to the need to collect data and look at our own systems and find ways to continue to improve. National collaboration on these goals, I think, is incredibly important. There's lots to learn from each other. I think it's not difficult to find systems that are doing things better, and I think that our goal there would be to look for best practices in every system out there and attempt to spread that information around to others. I think the main things we want to focus on today, though, really are enhancing performances of our EMS systems and all the different methodologies that we have to do that. And one of the ways, I think, to get there is through research and innovative technologies and treatments. And that's really kind of one of the areas that we'll be spending a fair amount of time on today, kind of focusing our attention in that spot. So unaided manual CPR has been around for a long time. I think, it's been taught to lay public, to professional rescuers, et cetera. We really haven't seen a significant change in the way we do CPR, apart from some tweaks and tunes, I guess, to rate and compression depth and all that sort of stuff. But really, overall, there's not been just a huge change in CPR itself. But I do think one of the things that we want to do is talk a little bit about the physiology of CPR. And we can start by sort of dividing it into two different halves, if you were. And so part of that really has to do with the compression phase. That is, when we press on the chest during CPR, what actually happens. And it's pretty straightforward. Obviously, we press on the chest. That raises the pressure inside the chest and directly compresses the heart. Excuse me. That forces blood out of the heart and out of the vasculature. It pushes air out of the lungs. And ideally, it pushes blood into the head, but it also raises intracranial pressure. It does that by sort of sending a simultaneous pressure wave through both the arterial and the venous side. So intracranial pressure frequently does go up during the compression phase of CPR, and the importance of that will be a little bit clearer as we move along here just a little bit. Let's talk just a minute about chest wall recoil, though, where we really haven't spent very much time in the past with what's going on there. And I think one of the things that's really important here is to realize what happens as the chest wall recoils back to its normal state. One of those things that happens is just as with normal physiology, we work on a negative pressure system, a vacuum system. We expand our chest to create a small vacuum inside the chest, and because our airway is open, air rushes in there to fill that vacuum, and that's how we function in a normal state. However, when we are in cardiac arrest, we switch that physiology to a positive pressure physiology, where we're now forcing air into the chest, and there are consequences to that change in physiology. So part of what's happening with the recoil piece is that that negative pressure, the vacuum that's formed in the chest, small as it may be, does have an effect on blood flow. That pressure differential between the periphery, where the pressure is essentially zero in a cardiac arrest, and the chest, where the pressure might be slightly less than zero, that pressure differential helps to flow blood. So one of the things that happens during chest recoil is that that vacuum is formed, albeit very slight, and that helps to pull blood back into the chest. It also helps to pull blood out of the head, and that's extremely important for flow through the brain and neurologically intact survival. So in essence, the full duty cycle of CPR really has to do with both the chest compression, the push phase, if you will, as well as the chest wall recoil phase, where sort of a pull action is going on, pulling blood back into the chest cavity. We've known for quite a while, through some really great research, that there are some very important factors related to the quality of CPR. And I don't know that I can stress strongly enough how important these three things are for the basis of CPR that results in better outcomes. In essence, the rate, depth, and fraction of compression fraction in CPR are the cornerstone of good quality CPR. And I think part of the concern with this is that many systems will tell you that they're doing very high quality CPR, yet they have no real way to monitor what the rate is, what the depth is, and what their compression fraction was on any kind of regular basis. And that makes it really challenging to know whether or not they're doing very good quality CPR. I expect they're doing it as well as they have been trained, but I think one of the things that we will agree that there's room for improvement on is how well are we actually looking at these things, and how well are we focusing our attention and our rescuers' attention on these three vitally important factors in CPR. So one of the ways that I think we can really improve the quality of CPR is to get real-time feedback. As I mentioned earlier, it's very challenging to be able to tell if you're doing CPR and meeting those three parameters on a regular basis and consistently without some sort of feedback. There are several different items on the market that provide feedback immediately to the rescuers on the scene, as well as collect data for folks to go back and review later on. And I think most high-performing EMS systems with good quality or good CPR resuscitation results are using some sort of real-time feedback, or at least very short-term feedback, so that the case is reviewed shortly after the arrest is over, and feedback is sent back to the crews in regards to whether or not they were pausing too frequently, their compression depth was wrong, their rate was too slow or too fast, etc. There are some other adjuncts that have come along in the last few years related to intrathoracic pressure regulation. We'll spend a little bit of time talking about that and the impact of intrathoracic pressure regulation in just a few minutes. I think everybody has had a chance to hear about active compression, decompression CPR. We'll also spend some time talking about that as we move forward. And then obviously automated CPR devices have been around for a while now and I think have matured. And we'll talk just briefly about some of the really important things that we have learned about automated CPR and that folks need to be aware of to ensure that they're getting the maximum out of their devices. So let me spend just a couple of minutes talking about this human cadaveric model because it's going to be very important to understand in relation to the impact that all these different therapies have on the physiology related to CPR. So this model basically is fairly unique and goes way back, obviously, to medical school for most of the physician population there. You know, they've been used in other ways for educational purposes. I myself am a huge believer in the use of cadaveric models as a phenomenal educational resource that is not utilized in EMS nearly as often as it should be. But there's really not ever been much use in the study of CPR. And that's one of the things we've spent the last couple of years working very hard to do is to try to incorporate a cadaveric model into CPR research. So part of what we've really been trying to do is establish a common platform, and by that I mean a model that we can reproduce consistently and the output of which, the results of which match up with live animal models, cadaveric animal models, as well as research that has gone on in the field. And our real goal there is to establish this common platform so that we can actively look at the impact that different changes to technique, different equipment, different adjuncts have on CPR. So it really is obviously in a cadaveric model all about the mechanical aspects of CPR. Obviously the biochemical aspects of CPR are lost in a cadaveric model. But what we have noted is that the flow tracings, the pressure tracings, et cetera, that we can generate with this cadaveric model mimic exactly what we see in both live animal and cadaveric animal models, although they are a bit attenuated. And I think part of what we're missing there is just the biochemical tone that is in the vasculature of a live animal, for example. But nevertheless, the pressure tracings and curves that we've seen have matched up very nicely and have fit with the similarities to our porcine models quite nicely. This research has allowed us to take a look at the impact of different techniques, different equipment, different methodologies related to how we do CPR, and has also led us to some very interesting additional things that we hadn't thought too much about before until now. And I'll talk a little bit more about those as we get a little further into this. So this translational research using this perfusing cadaver model, it has got some challenges that we talked about. Obviously, our primary goal is to make certain that the model itself is reproducing what we see in our animal models, and to date it has matched up extremely nicely. We obviously have no need for informed consent in real time. We do have obviously special permission from the donors for the use of their bodies during this research, but it's not the same challenge as attempting to gain informed consent to do cardiovascular and cardiac research in the field, which is almost impossible, as you can imagine. We felt very strongly about the need to develop this cadaveric model to work around concerns that what we were seeing in animal models might not apply to human physiology. Certainly the mechanical aspects of that related to body type and airway type and the ability to do CPR and all those things are quite different on animals than they are in humans. And so it was our goal to try to eliminate those possible concerns by getting this cadaveric model sorted out so that we could figure this out. Again, the other goal here was really just to take a look at how we're doing things, what adjuncts we're using to do things, what other functional issues are there related to doing CPR that have an impact on the quality of CPR, and how can we use this model to find improvements that would take us an incredibly long time in the field if we ever even came upon them in the field based on the ability to do research there. So this is just to show you sort of who's part of the team here. There's quite a large group of folks scattered all across the country that have been involved in this research over the last couple of years or so. So just to tell you briefly kind of how the research is done here, these numbers are a little bit out of date now in that we've had a larger number than 12 of fresh cadavers that we've utilized. They are perfused with saline mostly to clear out the clots and make sure that the vascular system is free to maintain flow. We use malar pressure catheters that are placed in various major vessels around the body as a way to measure pressure. We can also place flow sensors, Doppler flow sensors, etc., on vasculature as need be so that we can establish flow, for example, through the carotids, etc. The other thing that we try to make sure that we're doing is we're monitoring airway pressure. In reality, we're monitoring intrathoracic pressure because the impact that intrathoracic pressure has during very low flow states such as CPR is incredibly important. We also monitor intracranial pressure. We do that primarily because we're interested in being able to assess what's happening in the brain. The flows and the pressures to the brain are obviously directly related to neurologically intact survival, and our goal there is to be able to assess what's going on in the brain in real time with the various changes that we're making to CPR and the various adjuncts that we're using during CPR. The Foley catheters in the iliacs are basically designed to occlude flow to the lower extremities, primarily due to some of the shortcomings, I guess we could say, of the cadavers. Obviously, over time, the cadavers develop capillary leaks as the tissues break down a little bit, and the goal here is really just trying to keep the vascular system full so that we can get a better sense of what flows look like and pressure tracings as well. The airway is managed in a variety of ways. Primarily, they're intubated and ventilated as you would in a standard cardiac arrest. We have done a small amount of work on different types of airways, and if time allows at the end, we can chat about that a little bit as well. Excuse me. So when we looked at this cadaveric model related to and compared to the porcine model that we've done before, we definitely saw improved hemodynamics when we did high-quality CPR. I'm going to show you all of that as we move on through the talks here. But in the cadavers, the physiology was basically the same as far as pressure and flow tracings were concerned that we saw as during our work in animal models. And the ability to see what was happening with these, we felt you could look at a pressure tracing on a cadaver, and if you were blinded as to whether that came from a cadaver or a porcine model, you could not tell the difference between the two. So the correlation between the two was quite strong and made us feel very good that we were on the right track. As I mentioned earlier, we have done a little bit of work with supraglottic airways and airway management using carotid angiography during CPR to assess flow through the carotid and to the brain during the use of some of those devices. Again, we can chat about that some more toward the end of this webinar. So in essence, I think where we've gotten is a new model to study CPR physiology and to really expedite the future of research on what we need to be doing in CPR, what things really make a difference, what things are ultimately bad during CPR, and to be able to do that in a way that is immediately transferable to the field and will have an impact on cardiac arrest resuscitation rates in our patients. So there obviously are still some questions to go. I think the more we do of this, the more we realize there are many, many, many questions yet to answer. And we'll talk a little bit about those again as we begin to work our way through some of the science here. So let's step on off into this a little bit and see what things look like. So let me show you basically what you'll be looking at for most of the rest of this presentation as far as how things look. What you see in the green here is a measurement of intrathoracic pressure. The green lines in every slide will be related to airway pressures. As you can see, it's been highlighted here on the slide a bit. There's a central line of where the pressure is 0. And obviously anything above the line is a positive pressure. Anything below the line is a negative pressure or a vacuum. So what you see during compression and decompression is that there are changes in intrathoracic pressure that occur, and ways to enhance that can have a pretty big impact on our ability to perfuse these patients during CPR. Aortic blood pressure will always be shown in blue. Again, you see a very heavy highlighted line there to show the 0 line, and then the top of those peaks are the systolic pressure that we're able to generate during CPR. And then in pink is intracranial pressure. Again, we've highlighted the 0 line here, so you see that intracranial pressure both goes up above the line to be positive, but also may be negative in some cases. So one of the things that I do want to stress just a little bit is that while pressures are always important to ensure that there is blood flow and high pressures don't always mean high perfusion. So I think that the key here that we'll point out a little bit later is that, yes, you have to be able to generate enough pressure to result in blood flow, but if you have high resistance to that flow, you may simply be generating a pressure wave and not actually flow. So there are sort of two different factors to take into consideration when you are looking at these, looking at the output from some of these studies, and that is to make certain that, one, pressures are where they need to be, but also resistance to flow is where it needs to be. And we'll talk a little bit more about that as we move on through things here as well. So let's start with kind of where we've been for a long time. Let's start with unaided manual CPR and look at what that looks like in the cadaveric model as we intentionally do some bad quality CPR. So if you take a look at this slide, what you see in the airway, in the green at the top, is every so often there's a very large spike that goes up, that goes positive. What you're seeing there is those are positive pressure breaths that are administered by a BVM and an ET tube. So those big spikes are simply ventilating the patient as you would expect. If you look at the aortic curve, the aortic pressure curve there, what you see is very small changes both above and below the line. In other words, we're able to generate a little bit of pressure with each compression. That's the upward spike. We push on the chest, that raises the pressure inside the chest, and that causes the upward spike in blood pressure. But you see also in the pink a very similar change that accompanies that with the intracranial pressure. So in other words, every time we press on the chest, that pressure is transmitted very quickly through the vasculature into the head. So there's a pressure spike in the chest, but there's also a pressure spike in the head that occurs at the same time. So what you're seeing here is very, very shallow compressions, and what you see from that is that the peaks of the compression phase in CPR are quite low. In other words, it generates very little pressure inside the chest because the compression rate, the compression depth is way too shallow. In other words, we're simply not pressing hard enough to generate enough pressure to result in much in the way of flow. So here in this slide, what you're seeing is incomplete chest wall recoil. So the compression depth has been corrected, and what you see is the same positive pressure spikes in the intrathoracic pressure curve, the green curve, that you saw before. So the patient's still being ventilated as they were before. And you'll notice that the blue line, the aortic pressure lines, are quite a bit taller than they were before. That's because the pressures that are being generated are greater than they were in the prior slide where you saw inadequate compression. But there's something else here really important to notice, and that is if you look at the heavy line there, which represents the zero line, you'll notice that there's nothing going below that line. All the pressure in the chest stays positive all the time. And what that results in is the same impact on the intracranial pressure curves that you see at the bottom there. In other words, the intracranial pressure has all gone up, again, with very little bit of, a very small amount of it now in the negative, below the line. So what's happening here is that with incomplete chest wall recoil, the pressure in the chest is never allowed back to zero. And if you relate that to our very simplistic model that we were talking about earlier, where in cardiac arrest, the pressure everywhere in the body is essentially zero, if you maintain a positive pressure inside the chest all the time, the idea of expecting blood to flow back into the chest is difficult to imagine, because you're asking blood to flow from a pressure of zero to positive something or another, probably 2 or 3 or 4 here. So even though those pressure differentials are quite small, there is still enough of a pressure differential here to impede flows substantially. So in essence, what's happening with incomplete chest wall recoil is you are continuously maintaining a positive pressure inside the chest, and that is constantly pushing blood away from the chest and allowing the heart not to have an opportunity to refill, raising preload substantially, and thereby reducing cardiac output. So the pressures here are not too bad, but the flow is terrible in this model or in this situation because of the constant and persistent positive pressure in the chest during incomplete chest wall recoil. So in a nutshell, I will tell you that incomplete chest wall recoil is beyond really bad CPR. It is devastating to flow in CPR, and it's one of those very small details that we have to pay a lot of attention to because it has such a negative impact on flows during cardiac arrest. So here's another example of a rate that's very fast. The compression depth is close to where it needs to be. The recoil is close to where it needs to be, but the rate is quite fast. And again, what you note is that the pressures look a little better here. The pressures that they're able to generate, I think, are around 20 or so millimeters of mercury, which is not great, but pretty consistent for manual CPR. But what you also see here is in the intracranial pressure, the pink line at the bottom, those intracranial pressures remain up fairly high as well. And during the diastolic phase, that is the phase of the line that is in the negative, those are not terribly deep in the negative. That diastolic phase, i.e. the recoil phase, is when we're experiencing flow sort of out of the head and into the coronary arteries and all that sort of stuff during CPR. So a fast compression rate also results in not as good a flow as we would have if we were sort of right on the sweet spot. So one of the ways to really get on the sweet spot, in other words, to hit that rate, depth, and compression fraction that we talked about earlier, are some of the feedback products that are available on the market to assist and provide feedback in real time to the rescuers that are actually performing CPR. So here's one example. This is a Zoll monitor. And what you see in the center box there is quote unquote poor quality CPR. So it'll actually give you the depth of CPR. It'll give you the rate that you're doing CPR. In this case, 52, and you can see that box is lit up in red to tell you that you're not where you need to be. The column there next to that is released to ensure that you are coming off the chest completely. And then the performance index there, the diamond on the right-hand side of that center box, fills up to show you that you are, again, meeting all those parameters where you need to be. And if you compare that to the box on the right where the parameters are all being met, you can see what it looks like when you're indeed doing high-quality CPR based on this feedback. So the question really becomes, do these things really make a difference? And so what? This is great stuff to have back, but does this stuff really make a difference or not? So let me show you what the difference it makes is. So here's our unaided manual CPR recording. Again, you see the positive pressure breaths at the top. The green line is airway and intrathoracic pressure. Excuse me, the blue line in the middle there is blood pressure, and the intracranial pressure is shown at the bottom. And let's compare that unaided on the left and aided on the right. In other words, CPR that hits all three of those sweet spots is shown on the right. CPR that does not, that's just performed without any assurance that you are always in the sweet spot, is shown on the left. And the differences are pretty striking. What you notice on the right compared to the left in aortic pressures are better systolic blood pressures, but you also notice lower diastolic pressures, meaning more vacuum in the chest and lower pressures. If you look at the intracranial pressure, that's maybe the most important part of all this. So you notice that there is greater intracranial pressure during the compression phase. In other words, the pink line shows taller peaks during compression. But look at the difference in the diastolic phase, and look at the difference in negative pressure or vacuum that occurs in intracranial pressure during aided CPR versus unaided CPR. And that is phenomenally impactful on the amount of blood flow that moves through the brain during CPR. So the point here is that those devices that aid in CPR to ensure that you're on the sweet spot, and the research that's looked at the variable outcomes across the country, I'm specifically referring to the ROC trial, when those were all evaluated to look at the quality of CPR related to the outcomes in the various centers at the ROC trial, very clearly demonstrated that places that were on the sweet spot, that hit those rate, depth, and compression fraction numbers consistently, had better outcomes. And the reason for that is shown right here in this slide, and that's because getting those parameters exactly correct results in better aortic blood flow and a change in intracranial pressure, which is important. The reason that is important is the flow through your brain is the difference between the mean arterial pressure and the intracranial pressure. So in order to get better flow through your brain, you need to elevate the mean arterial pressure and or reduce intracranial pressure. So another way to impact what's happening with pressures inside the head is intrathoracic pressure regulation. This has to do specifically with the impedance threshold device. And this device, although it's placed on the endotracheal tube or on the airway, is actually a circulatory-based device. And what it does is result in a deeper vacuum inside the chest. The impedance threshold device is designed to essentially require a deeper vacuum before it allows air to flow in. What that does is make a deeper vacuum inside the chest, meaning a greater negative pressure, so a lower pressure inside the chest compared to a standard open airway. So let's take a look at that differential in adding on the impedance threshold device and comparing that to what we saw just a few minutes ago related to unaided and aided CPR. So the aided and unaided CPR boxes here are the same as we talked about a few moments ago. If you look at the third box, the box on the right, what you'll notice is now the green line actually extends below the line, meaning that the vacuum is being created in the chest. And you'll notice that the aortic pressures have increased, and you'll notice also that the intracranial pressures have decreased during diastole. So in essence, you have worked both sides of the equation to improve blood flow through the brain by raising mean arterial pressure and lowering intracranial pressure. If we carry that to an even further extent, we can utilize something called active compression decompression CPR. The way this works is during the recoil phase, the relaxation phase in standard CPR, that's actually an active phase in active compression decompression CPR. So what happens is you do compression as you might normally during standard CPR, but during the recoil phase, you actively lift up on the chest with about 10 kilograms of force in order to enhance the amount of vacuum that occurs inside the chest. So we'll do our quick comparison as we did a few minutes ago. Again, you can notice the positive pressure breaths at the top, the relatively low blood pressure and intracranial pressures that are generated by unaided manual CPR. If we compare that to active compression decompression CPR, what you'll notice is a substantially deeper dip by the green lines at the top, showing substantially greater or substantially lower is a better way to say that, intrathoracic pressures, and a substantial increase again in the aortic pressures, as well as a significant decrease in the intracranial pressures during diastole. So again, improving the mean arterial pressure while reducing the resistance to flow by dropping the intracranial pressures. I wanted to just show you very briefly a couple of slides here that are related to the use of the ITD during active compression decompression CPR. And if you look at the box on the right, that is active compression decompression CPR without the ITD. What you see there is a complete loss of most of the the intrathoracic vacuum during that time. The aortic pressures haven't changed an awful lot in this short example here. There is a bit of a trend in the intracranial pressure, though, which is concerning, and that's why the active compression decompression device should always be used with the ITD. That additional vacuum is vitally important to ensure maximum cardiac output and maximum impact on reduction of the intracranial pressures. Automated CPR has been around for a few years. Again, we'll go back to our basic slide of unaided manual CPR so that we can compare automated CPR to that. And what you'll notice here is, again, a substantial increase in systolic blood pressures using automated CPR. You'll also notice that there is a significant increase in the intracranial pressure during CPR and not quite as much impact on the diastolic portion of the intracranial pressure during the recoil phase. So in essence, what you see with automated CPR devices is they are very good at sort of the push phase, but that is associated with less of an impact on the intracranial pressure phase, and therefore negates a little bit of their enhanced ability to drive pressures because the resistance is increased a little bit at the same time. So I guess there's no silver bullet here. Everything has a little bit of a negative side to it as well. So this is a look at automated CPR, again, compared to unaided CPR on the left and automated CPR with the addition of the impedance threshold device. And the main thing I want to point out here is, again, in the green lines at the top there, you notice substantial negative intrathoracic pressure or vacuum inside the chest that occurs with the addition of the ITD. There is an increase in the blood pressure compared to standard automated CPR. And if you look closely, it's a little hard to see in this slide, but there is an enhancement in the negative part of the intracranial pressure when the ITD is used as well. So again, the point here is the manipulation of the intrathoracic pressure is vitally important no matter what type of CPR you are doing, and that it has an effect both on the amount of the reduction of preload to the heart and therefore better filling of the heart for better cardiac output, but it also has an impact on reduction in intracranial pressures, which results in decreasing resistance to flow through the head and therefore better flow through the brain during CPR. So let me just kind of wrap things up here a little bit, and we'll move on to questions and some other topics that we wanted to discuss. Obviously, we all know the impact of cardiac arrest overall. I hope I've been able to provide a little bit better understanding into the physiology of CPR and things that can be done to hopefully manipulate the way we do CPR to maximize cardiac outputs and cerebral blood flow to improve neurologically intact outcomes. There are a lot of tools out there. I know you've all seen and read about many of them. I hope we've been able to give you a little bit of insight into what those tools do and the legitimacy of those tools and the impact that they're having on the physiology in an effort to give you some better insights into what you need to be doing for your system to improve your cardiac arrest outcomes. So with that being said, I'll stop for just a sec and we can address some of the questions that we've had coming in.
Okay, Joe, we have a couple, that relate. First of all, we'll talk about feedback, and the question coming to us from one listener is, how's the real-time feedback working, the invasive method?
I'm not sure what you mean by the invasive method, AJ.
Well, I guess maybe in your cadaver studies. Let me go with another one. It seems logical that feedback is valuable. Why is the research not shown a clear advantage to live feedback? That comes from our good friend Bill Toon.
Oh, I think that's a great question. I don't know that I have the answer specifically to that question. I think it's inconsistency in application. I think it's a misunderstanding of the importance of a lot of very small details related to how we're doing CPR. And because those numbers are so small, it's going to take a very large clinical study to show difference. Again, what I hope we were able to do with this cadaveric model is to demonstrate that those feedback devices result in better quality flow during CPR, and all those differences may be very small and difficult to see clinically. They are making a difference, and I think the impact of those the feedback mechanisms is incredibly important to ensure that we are indeed in the sweet spot, as we talked about before.
Okay, I'm going to follow up with another Bill Toon question about, doesn't the etiology of the cardiac arrest have an impact on how the patient will respond to treatment?
I think the answer to that is yes. And I don't know that the studies that we're doing are going to elucidate much on that from the standpoint that we're really looking to see, are there things that we can do in the way that we do CPR that can make a difference to all patients. So I think there's no question that, the numbers bear out that patients with VFib arrest tend to do better than with other rhythms. But this cadaveric question isn't really going to get to that answer.
Okay. What's your opinion of positive oxygen insufflation as opposed to PPV for the first maybe 8 minutes during minimally interrupted cardiac resuscitation?
I think the use of passive O2 during that time frame makes sense. The studies that I am aware of, I think look like the physiology makes sense from the standpoint of there being enough O2 in the bloodstream, if you can circulate it around for a while, to buy you some time and not really need to aggressively administer O2 during that time. I also think there's potentially some advantage to not pressurizing the chest with overventilation, as we have always been prone to do in the past, and that has a big impact on our ability to resuscitate these patients.
Can you address, Joe, some of the work that you and I and others have seen in the lab where, although mechanical CPR seems to increase intracranial pressure, the advent of the 30-degree tilt or heads-up CPR, what that has done for the results?
Sure, I'll be glad to, AJ. What AJ is referring to is we've noted in the laboratory using this cadaver model the changes in intracranial pressure that occur with the impedance threshold device and others that we've talked about already. We've also, I've sort of come to the conclusion that the cardiac cerebral blood flow is very much like a siphon, and that we are pretty good on the push side of that, but we're not so good on the pull or the return side. So what we've noticed is that if you raise the head of the bed during CPR, very high quality CPR, mind you, the intracranial pressure goes down fairly substantially. I think what's happening there is that gravity is assisting blood to flow out of the head. About 70% of the blood in your head is venous, and obviously doesn't do us much good during cardiac arrest and CPR times. So we want that blood out of the head so that we have room for oxygenated blood to get into the head. So gravity helps to flow that blood back into the chest. The caveat to it, of course, is that you have to be doing very high quality CPR in order to generate enough output pressures to overcome the need now to go uphill for 18 inches or so, because you're now pumping blood up into the head as opposed to level into the head.
And we have a question here from Montgomery County Fire Rescue from Chris Tozo, and he's asking, is there recent data to support improved survival to hospital discharge with CPC scores of 1/2 with the use of the ITDs?
I don't know specifically with the ITD. Certainly the studies that looked at active compression, decompression CPR, which incorporates the ITD, showed about a 50% change there. So that data was actually used by the FDA in approval of that device.
Yeah, and there's a couple questions really that bounce around about the 2015, the AHA conclusion that there was little difference and, impact and all these other things. I guess my comment from all that we've been working on for December JEMS is that there's many nuggets that make a big golden nugget, and there's not one of these things alone that really makes the difference. You want to comment on that?
Well, I think you said that beautifully, AJ. No one of these things is going to make a huge difference. In relation to the 2015 guidelines and the conversation around the impedance threshold device at the time, that sort of goes back to that slide I referenced earlier on in the webinar. If you looked at that data, what you found was a vast variation in the quality of CPR across those various sites that were collecting data. And several analyses have been done since, looking more carefully at that data. And what we have learned is that for the ITD to work, you've got to be doing very high quality CPR. And so I think it's a bit of an effort to assume that everybody was doing really high quality CPR and therefore the device must not make a difference. And the real answer is the device does make a difference, but you have to be doing very high quality CPR to see it. And what that said to us is that we still have great variability in the quality of the CPR that we're doing, and thus the need for feedback devices that make certain that we get into that sweet spot that we talked about earlier.
And the other caveat, and I know you've used both the Auto Pulse as well as Lucas, the caveat is that the mechanical CPR, when people try and say it's not equal to manual CPR, it may not be when it's working, but the reality is that over time, without interruption, seems to be a key ingredient. Do you agree?
Well, I think if you want to look at the studies related to manual CPR versus mechanical CPR, I think the answer there is that mechanical devices are not doing better CPR than people are, but they are definitely doing more consistent CPR than people are. And the real issue is that people can do it as good as that machine can, but they have to practice a lot. They have to train incessantly, and they have to be perfect all the time. And, I think the reality is that just doesn't happen, and that's why those mechanical devices appear to do, quote-unquote, better CPR than people. But I think the answer is they just do more consistent CPR at a level that people can't maintain in the field all the time.
Yeah, and I have to chuckle because the other day a firefighter said to me, AJ, if you followed that philosophy that we should still continue to do just manual CPR through snowbanks, downstairs, at landings, then we should go back to the hand pump fire apparatus because we had good pressures when we did that, but if you stopped pumping, you had to go back to prime again. So, in the fire service vernacular, I thought he really got it. Can you add a little bit, Joe? Can you add a little bit about what we've seen with ECMO in this whole resuscitation process?
Sure, I'll be glad to. So just a quick comment on what you just said. I would agree completely that the ability to do CPR while you're on the move, whether that's down the stairs or in the back of a truck, is extremely limited, and that is absolutely where mechanical devices really make a huge difference in that you can deliver quality CPR in an environment that doesn't suit manual CPR at all. As far as ECMO is concerned, I think we're seeing a surge in efforts to get ECMO into the field. There are several research projects that are starting in the U.S. And efforts to get ECMO out to EMS and cardiac arrest. There have been several European studies, many of which are still ongoing. I think part of the value of ECMO is the ability to provide, continuous oxygenation despite a cardiac arrest, and what that really does is buy you time to get to a cath lab, et cetera, so that you can fix whatever the core problem was that caused a cardiac arrest in the first place. So the real challenge there is going to be the equipment and the training of the folks to be able to perform that insertion very quickly and be able to get access to a cardiac arrest patient in a fast enough time frame to salvage them. Once you can get that thing in place, I think you buy a fair amount of time for much more substantial procedures to fix the root cause that started the problem in the first place.
Yeah, and I happen to have my hand on the crystal ball because I know for the last year we've been working on this December issue of JEMS. So for many of your questions out there that we may not have time to answer, we will answer them, in fact, after the webcast. But the December issue of JEMS is going to feature about 80 pages of content that's just from all over the country as well as all over the world that addresses these things. And one is an article by you, Joe, and it talks about your work with Collier Fire Rescue. And when you introduced the rescue CPR system, would you address what happened in the first 8 patients?
Well, sure, AJ. So the experience there was the implementation of rescue CPR, which is active compression, decompression CPR, into a service that was high-quality manual CPR. Before that, our first eight patients, I guess, that we responded to in cardiac arrest, we had 7 neurologically intact survivors, with the 8th patient actually being resuscitated from a cardiac standpoint, but was unfortunately riding his bicycle when he had a cardiac arrest and sustained a pretty severe head injury, which he ultimately succumbed to several days after his ROSC and hospital stay during that time. So the numbers there have continued to be pretty impressive. That system is in the suburbs of my larger system, which is the city of Memphis. So our patient population is quite similar, et cetera. And that system has surpassed the ROSC rates for the city in the last few months. And the city ROSC rates were already in the upper 30%. So I've seen pretty impressive results out of the active compression decompression CPR system.
That's great. And I just also want to mention in here, I was up in Rialto, California, the Rialto Fire Department, and they're going to be featured in December JEMS as well. In fact, our cover story, and they had some people that took all of these Take Heart America initiatives and modified their system, and actually their statement is they had to untrain people on what they knew about resuscitation, and they brought their Utstein levels from the 60 up to about 60-71%, which is almost unheard of. And the key ingredient there is they get the auto pulse on within 30 seconds, and they say they never shut that auto pulse off, and that's been a key ingredient. And then as soon as they get the auto pulse on, they move the patient to the stretcher at a 30-degree tilt, the head up. They use the impedance threshold device. They use the asphyxia oxygenation rather rapidly, and then start moving on some of the other things. But it's not really about defibrillation anymore, and it's not really about epinephrine. It's all about never stopping those compressions. Do you have any comments on that, Joe?
Well, I think there's great value in maintaining that circulation. Certainly in our animal model work, we've noticed that with very high quality high perfusion CPR, the need for medications has dramatically reduced. We frequently, after 15 minutes of cardiac arrest and about 6 minutes of high perfusion CPR, give the equivalent of about 0.5 milligram of epinephrine in one shock, and we get ROSC back in a majority of cases. So, you know, I think we'll continue to see that medications in cardiac arrest are of questionable value and or maybe only in specific circumstances. For example, a specific arrhythmia of some sort may benefit from an antiarrhythmic agent. So, you know, I think that's it's all part of maintaining flow and preserving heart and brain tissue with the work that's being done there.
Okay, before we close, a couple things I think deserve clarification. Oliver Watts from Southeast Coast Ambulance Service is asking, with the aortic pressure less than 30 millimeters, will this correspond to reduction of coronary perfusion?
Well, so obviously coronary perfusion is directly related to the aortic pressures. I think maybe an easier way to summarize all that is we have noticed that just as the cerebral perfusion pressure is the difference between mean arterial pressure and intracranial pressure, a similar ratio holds in coronary perfusion. And what we have noticed is that the same impacts that I showed you related to cerebral blood flow also hold for coronary blood flow.
Okay. Here's another question here. How do you know that changes in ICP affect CPP in a positive manner? Why not measure CPP to actually know how the perfusion of the brain is affected?
We have actually done that utilizing microspheres and other methodologies, and have noted, essentially the same results. I didn't show all that today because the pressure curves are a little bit easier to understand and a little bit easier to compare.
Okay, and you had stated here, and this is from Barry Burton and Jefferson University East Falls campus, you state pressure is not the same as flow, yet the graphs you presented are pressure time curves. Can you interpolate flow from these measures?
Yes, that's basically what we've been doing. Again, I didn't show all that. So part of what we've done is actually also use Doppler flow sensors on vessels to look and see what flow looks like in those situations. And again, for the desire to simplify the presentation and be able to show those differences between all these different the impact of all these different things that we were looking at, the pressure curves were much easier to utilize.
Great. One final question here is how do we adjust and account for the Hawthorne effect on the pressure differences you mentioned in unaided versus aided CPR?
I'm sorry, ask that one more time.
Well, it's how do we adjust or account for the Hawthorne effect and the pressure differences you mentioned in unaided versus aided CPR?
Well, I don't know that I know the answer to that, but I think that if you look at just not doing CPR in the sweet spot, you get curves like I showed you. You get pressures like I showed you. And whether or not it's paying attention because somebody's looking at you or is it really about the sweet spot, I think the data analysis from the ROC trial made it pretty clear it's about the sweet spot. There's no question there's a substantial difference in outcomes at all forms if the CPR was within parameters for rate, depth, and compression fraction. And I did notice a question of someone asking about compression fraction. What compression fraction means is that you are on the chest doing compressions compared to the total cardiac arrest time. So if the total cardiac arrest is 1 minute long and you are on the chest doing compressions for 30 seconds, you have a compression fraction of 50%. So the value there is to certainly be above 50% and really above 90% in maintaining those compressions. It's back to what you talked about earlier, AJ, about not taking pauses and doing continuous CPR.
Yeah, and there were a lot of questions about, which devices were used, Lucas, AutoPulse. I can just tell you that in what you're going to read in December JEMS, it is a key ingredient to use mechanical CPR, whatever you're using. And so, all of these things considered, mechanical definitely is starting to come to the vogue. There was a question, though, Joe, about using, somebody was questioning whether you can still use the ITD device with manual CPR to a similar effect, and I think the answer is yes, correct?
I think the answer is definitely yes. Again, assuming that the CPR is as high a quality as you can make it. In order for the ITD to really show substantial benefit, you got to be doing good quality CPR.
And do you feel the ITD provides enough negative pressure to negate the use of positive pressure ventilation in standard CPR?
I don't know that we know the full answer to that. I think you obviously have to do positive pressure ventilation. That's just simply necessary and sort of our only option in cardiac arrest. But I think it's absolutely important that we do that breath as gently and smoothly as we can, that we do not overventilate that patient. And by that I mean we don't use very large tidal volumes. We don't have a rate that is too fast, and that we ensure that if we put 500 cc in, we're getting 500 cc out. Usually the reason that we're not having that happen is because we're ventilating way too fast.
Okay, and a couple other things. First, there was the question about the rescue CPR device. Has that been approved for use? Absolutely, yes. And you'll be able to get the PDF after this to be able to see that. But it's certainly, you can contact Zoll. It's all been approved by the FDA and is being used throughout the country. What about the King versus endotracheal tube versus iGel? Any of the rescue airways make any of a difference in this whole study that you've been doing?
Well, that's a really good question, AJ. We could spend a long time talking about that one. I'll have to say that we have only done that a very small number of times. I think not enough yet to be able to answer that question with any authority. There may be some impact on carotid flow with some of the supraglottic airways compared to an ET tube, but I think we don't have enough information yet for anyone to use that clinically. I can tell you it's high on our list of things to look at. I will also, sort of in a related comment, note that when we placed a cervical collar on many of these patients during our CPR studies, we noticed that intracranial pressure went up. And that in essence, the concern there is that the use of a cervical collar during cardiac arrest, which may be being done to help keep the neck from moving too much and therefore keep the ET tube or airway from coming out, may be compressing the carotid vasculature externally and therefore impeding flow a little bit. I can't give you a lot of details as to how much, because we haven't noticed anything other than it definitely increases intracranial pressure. We're going to have to look a little bit more about what that means in the way of flow. But I would say if you're going to use some way to help secure the ET tube, try to keep that collar loose and consider using other things that don't put direct pressure on the neck.
Yeah, and the added influence of something like another rescue airway inside the device that puts a counter pressure along with the external collar pressure, I think adds to that, does it not? Maybe. It certainly intuitively seems like it could, but we don't have enough information yet to answer that question. Okay, well, we're going to wrap up. This has been great. There's been a tremendous amount of questions. We'll try and get the other questions that weren't answered to Dr. Holley to get answers to you. But one thing I'll promise you is that our staff's been working for a year to present some stuff that's going to blow your socks off in December JEMS. All of these things, from ECMO on the streets of Paris to what's coming in Minneapolis to cath lab results from Lincoln, Nebraska Fire Department, all the way down the road to Rialto, California, are just going to give you incredible insight. So if you still have questions after you read December JEMS, email me, because I'm going to tell you this is an epic piece of work that all of our authors have been doing, and support from Zoll and everybody else is greatly appreciated. Zoll has been tremendous in the area of resuscitation, tremendous in bringing this information to you. It's a whole new paradigm that we are glad you were able to witness and be with us. Don't forget that we're going to archive the jems.com/webcast within 24 hours so you can share it with your colleagues. You're going to be able to download a PDF, and we hope this has been very informative for you. We've certainly enjoyed bringing it to you, and we hope to see you back for another JEMS webcast real soon. So signing off from here in San Diego and Memphis and Tulsa and all over the world, thank you very much.
Okay.